I went down University Avenue and it is terrible.
It just came in that way and it wasn't
I
bad.
mean, it's terrible from the synchronization of the lights.
Oh, yeah, they're out of
From
sync.
there.
They're out of sync.
Okay, getting reverb. I'm hearing.
Somebody's audio needs to be off. Oh, is it in here? No. I think there's an extra thing in there. In the new one. Yeah.
Wow. That's a baby. Oh.
Were you talking to me? I was just saying, I don't need my laptop. I'm like, what was it? This, I was talking to myself. I was having a conversation in my head.
Into everything. Into everything.
Oh, you know, you say, you're waiting for him to take his first step. And then they do and you go, damn, will they ever sit down again? And talking is the same thing. Still here.
So it hits. Yeah. It's like when they start saying no.
Oh, yeah. Oh, yeah. Yeah, you don't hear.
Yeah, I hear it.
Okay. Two. Two, that'll be it too.
If you can hear us online, we're waiting to get enough people to start the meeting.
From the speaker?
Yeah.
I just know I hear things.
They didn't know the meeting was today, right?
We put it out. Multiple times.
Okay, so what you want to do?
Let's give them 5 more minutes.
Okay, we're still hearing
It's the speakers.
speakers now.
What I found with Zoom is that unless I tell it from the
YouTube?
outset that I don't want to use the computer audio, it will continue to use. So you may have to log out of that one and come back on. She has the mute.
Demetrica is saying mute your YouTube.
YouTube's muted. This is muted. Is there any other computer on?
Yeah, but that's where the sound comes from. It's actually.
Everything's muted on yours, Ashley.
Can't mute that one because that's where it's not mute.
No, it's
I found that this happens to me all the time when I try to use 2 computers at once. You have to, at the beginning, when you log on the second one, it says, do you want to use computer audio? You have to say no. And then it will only have 1 or 2 computers, or 1 or 2, whatever on the audio.
Can you hear us, Cheryl?
Cheryl, can you hear us?
Yes, I can, and there's no echo, at least
Okay.
online.
Nancy, can you hear us? Okay,
Thank you.
sorry, y'all. I hate not starting things on time.
You and me both, and I was afraid I was gonna be late.
My better half says I have issues.
We could talk, but. I have issues with that too, but I know exactly what mine is.
Me too.
Mine was purely cultural and having come from a country where no one's ever on time into a country where people are always on time. It's quite a. I'm really obsessive about it.
Shane. Like, who's the other one? Shane. Okay. Ken says he'll join by phone in a moment.
Denise has a really hard time getting here for this thing.
Okay, you want to go ahead and start? Okay. Want to call to order the Children's Trust board workshop on maternal child health initiatives, August the 12th, 2024. And, so what we're going to do on this one, I'll do a couple announcements. First one is any member of the public wishing to be heard should come forward to the podium at the appropriate time and introduce themselves to the board. Members of the public recognized by the chair will have 3 minutes to speak on a single subject matter or to address the current motion on the floor. The clerk of the trust will function as the official timekeeper. We'll do roll call later. Now, because, member Twombly would like to participate, I'm gonna go ahead and, although we can't vote. So,
Yep.
if, I'll go ahead and read it. If quorum of the board is physically present, the board may determine that there are extraordinary circumstances that allow a board member to participate by electronic means. If the board makes such a finding, then the board member or members that are attending the board meeting by teleconference or other technological means may participate in board discussions and vote on trustee business. Such a finding of an extraordinary circumstance may be made by a resolution of the board or simply by motion, along with the lines in light of trust member board Twombly. The board member Twombly has requested to participate in the board meeting remotely due to the circumstances, which is she is doing work that requires her to deal with the hurricane. The board deems this an extraordinary circumstance. Therefore, we'll do the motion later if we get an action. So Cheryl, we want you to participate. We'll get you fixed up when we can, but we have to have enough people. So. Well, that was fun. And the next thing I want to do, Dr. Hart, I want to apologize to you for not doing a very good job with knowing that you were there at the last meeting. I believe you said that you felt invisible, and I apologize for making you feel invisible. And that we have worked on it, and you are right front and center with anybody else that is ordinarily behind us, so that we can see if somebody is raising their hand, because we want you to feel that you're a valued member of the board. So with that, we can't do the agenda review and approval, so I guess we just go into the discussion. Executive Director Kiner, would you be kind enough to kick it off?
Yes, sir. So we are here this afternoon to have a discussion about maternal child health. We will be releasing an RFP in the next 45 to 60 days. And we wanted to cover, basically provide you with an overview of maternal child health in the county. So at this time, I'm going to call upon Mia to come forward and start our discussion.
We've got two handouts.
Presentations.
Okay, so which are they the same?
Yes, the one that was handed out to you is updated from the one that's in your notebook.
Okay, so we should use this one.
Yes, sir.
Thank you.
Yes, sir.
Okay, so this is the first of two plan discussions on maternal child health. That's being in the background. Can you not hear me?
Nancy.
But Dr. Hart, can y'all not hear?
Nor can Cheryl.
So I think we're
So
gonna have to
that-
unmute this.
I can hear her a little bit, Lee, not very well.
Okay, can y'all hear now?
Can you hear me?
Yes,
Mia,
We can hear you, Lee. We just couldn't hear Mia.
okay. And she's much more important. than the microphone.
Yeah.
I can start from one of these that are next to the door.
Or you can just sit at a table, you got a long presentation.
I like that better. So this will be let me know if you can you hear me now?
I'll hear.
Perfect, okay. So this will be the first of two discussions on maternal child health. Today, we're going to have a presentation on the status of maternal child health in Alachua County. And let me go, presentation,
Beg your pardon?
waiting for the presentation to show. And we'll go right into our agenda. I'm gonna talk about, our investments for 23-24. So I'll highlight those. We'll have the presentation on the status of maternal and child health, and we'll discuss gaps and concerns and discuss ideas for expanding funding for the future. And from there, that will be the end of our presentation for today. So whenever I talk about maternal child health or early childhood system, I always use this, and I really like this one specifically. And the reason being is that it fits underneath health. When we talk about child health, we also talk about maternal health as well. So if mom's doing well, baby's doing well, and vice versa. This fits underneath the priority for goal of 1 for us, which is children and youth are healthy and have nurturing caregivers and relationships. So right now, these are our funding, what we invested in for this fiscal year. And if you look at it, we have newborn home visiting program. We have our what we're calling Flourish Alachua, our postpartum doula training and supports. We also added in doula-friendly hospital initiative, and we have our family partner at OBGYN practice. And lastly, we have the UF maternal health access and listening session and data collecting that we're doing this fiscal year. So for those, it's about 623,000 that we're investing in for this fiscal year alone. Next fiscal year, we're hoping to also fund, continue to fund the newborn home visiting program, continue our work underneath Flourish Alachua, which is our postpartum doula training, and finish our work with doula-friendly hospital initiative. Along with the UF maternal health access, we're bringing in and funding the navigator position that UF Maternal Health has, and that will be in January of 2025. Right now, that position is funded underneath the county's funding for health workers. And then, of course, we have the remaining of that funding will go towards our maternal and child health RFP. And I'll pause there for if you have questions.
Yeah, I do.
Yes.
So you left out the family partner, or you recommending we drop that?
I am. And the reason being is, and I've discussed it, it's not news to our staff that's here. One of the reasons being is that we want to be able to expand. It's a great program. Don't get me wrong. It does exactly what it needs to do for that practice and expanding some of being able to introduce families into newborn home visiting program. However, what we would like to do is be able to expand that throughout the county, and to be able to have where more of our community could benefit from having that role. And with that said, we have the navigator position. There's other ways of being able to do it with the RFP funding as well.
So I guess, because one of the things that I loved about that family partner concept was you're getting the moms right when they show up. The practices that we were in were high-risk moms.
We were only in one practice.
Or one, okay, because at one point you had talked about 2. Where
Yeah,
did you
but
end?
We weren't able to make that happen, so we've only been in one.
One, okay. I mean, I would think just being able to have on-site availability to have that contact, so I'm.
And that is still the goal.
Okay.
That is definitely still the goal, to be in a practice where women from all over the county.
So in some fashion, that's still gonna be something that we're addressing, whether it's through the navigator. So maybe when you get there, explaining a little more what the role of the navigator is would be helpful then to understand how one navigator can cover a whole county, since moms come in 5 days a week.
So let me explain it here, because you may not hear it anywhere else in this
Okay.
part. So the navigator right now, what she's doing is she's mapping the system of what resources do we actually have in Alachua County, so that they can look at how they can, send families out. So that is what she's doing right now. She also has other health workers that work with her right now as well. So for us, underneath that RFP, that's one of those things that this could fund, but it's pushing it out where it's not just the navigator's position. Yes, she can provide, direction in terms of mapping, but we're able to also offer a RFP if that's what we decide that's needed, that could push it out to more people in our county versus just one practice and those attending that one practice. The other parts that we have to look at is that we also have resource centers at this point too. And there's also health workers and navigators along in all of those resource centers. So for us, is being able to look at our system as a whole and being able to figure out how can it work together and be able to still be able to meet the needs of moms, babies, and families and serve them well and to get them where they need to go. So we're just looking at a bigger system. It worked. It was a beautiful system. There's that, the person who was over it, she did a wonderful job. It speaks to that, but I would love to take that and duplicate it all over our county versus just one.
Okay, Dr. Hart, Ken, Cheryl, you have any questions? Okay. I thought the purpose of that was there was a trust factor that maybe, that people weren't comfortable. And the thought was by having somebody with the practice that maybe that barrier could be overcome. So do you think with the approach that you're taking, that it will be as effective, if not more so?
We'll have to build that. We'll have to build that trust wherever those positions are, whether it's the resource centers, we certainly see that there where they have, been able to build that trust and build those relationships with those who they serve. The same thing happens there. And I'm sorry that I forget her name, but the person who did our family partner in the OBGYN office, yes, she did. She had great trust with the families that are there. But trying to build that took time to be able to build that level of trust. We just need to be able to have it at a deeper and bigger, larger level. And to me, I'm very hopeful that we do that. But right now, it's just a resource that only a small subset is, getting, and not everyone else is getting that.
I hear both ends of that, and for me, and part of the reason I raised it is not just the issue of trust, but it's the issue of timing. Well, it's the issue of timing. Yeah, it's when and where, because we know some moms refuse this kind of service, right? And so I think that when and where you catch them is just as important as how many you can have a lot of people, a lot of different places, but if you're not catching the mom at a point that they're receptive, will we lose more moms than we engage? So however we do it, and that can be part of our conversation at the end of how we build something like that into the RFP. I think it's partly a matter of trust. It's partly a matter of this is the practice you're going to. These are the doctors you trust who are now recommending that you talk to this person too. But it's also just a moment in time where receptivity is likely to be at its highest. And it may not be when you're headed at a resource center where you really went to talk about something else. So that's just that was my concern about losing that as a specific niche in this.
Dr. Hart?
I just want to remind everybody to use your microphones, because if you're not using the microphone, we can't quite make out what you're saying.
Okay.
Did you not hear me, Nancy? Because I've got a mic right here.
Maggie, I couldn't hear you before, but I'm hearing you fine now, but I couldn't hear Marcia at all when she was speaking.
I think none at all.
Okay, thank you.
Okay. So one of the things that I looked up is what is maternal and child health? That's one of those definitions that sometimes can be kind of puzzling, and there's no simple definition for it. The population can be specific sometimes, whether you're talking about moms and children, but sometimes you're talking about fathers as well. So really the health of moms during pregnancy and childbirth and the postnatal period, and the health and development of the infant up to their first birthday is what we're looking for here at the trust. And of course, we want to be able to build strong families. So incorporating the partner that's there for the mother is very important as well. So when we look at how it's impacted, and we look at the social determinant of health, there's a lot of different definition of what health is. And the heart of maternal and child health work lies in its goal of creating a health equity and promoting social justice and understanding the social determinants of health. It's important to know we are not just talking about the physical health, but mental health, social well-being. Those are also some areas that, we need to be able to look at when we look at how funding can be impacted. So with that said, I'm going to talk about Healthy Start a little bit before Julie comes up. And the purpose of Healthy Start program is to improve health outcomes before and during after pregnancy and reduce racial ethnic differences in rates of infants, deaths, and adverse prenatal outcomes. Supported by federal and state office, there's a Healthy Start for every county in the state of Florida. So the staff, our local one, doesn't just take care of Alachua County. They have a lot of counties underneath their hat. So they have a lot of information. They do a lot of great work. With their array of service for birth and postpartum families is essential part of our community. And through a community consortium, Healthy Start fosters community, state, and federal partnerships to improve health care quality and access. And this includes addressing gaps in services, co-creating services that consider different cultures and languages, increasing awareness of maternal and infant health issues, focusing on factors that affect health with community partners, community education, collecting community data, and building community collaborations. So in partnership with the community partners like Healthy Start in North Central Florida and UF Maternal Child Health, to me, we're able to see some changes in transition, what we're looking at in Alachua County. So next slide. So as Julie comes up to present, one of the things that I want us to do is I gave each of us a piece of paper that has on it community concerns, themes, gaps, community impact and investment. And I want you to write down what you hear her saying. What are your concerns? Listen and write down the gaps. Consider what you would like to expand investment funding in based on what she's sharing, and consider what community partnerships could be leveraged. So maybe we're not offering funding, but there are ways for us to be able to collaborate more so together. So consider that. So I introduce Julie from Healthy Start, and she'll come.
And Julie, before you get going, Dr. Hart, you have your hand up.
Yeah, I just had one question for me a couple slides back, because I noticed that she talked about maternal child health is talking about infant health, but what happens to people who don't have a live born? Aren't we concerned about some of the fetal mortalities as well? And I'm not trying to press this agenda, but some parents are really sad that their baby died before it was born. Other parents aren't too sad, but some parents are very sad. And I just wonder how we work them in.
They are worked in, and I would say that's part of what Julie's going to share in her presentation too.
You good?
Mhm.
Dr. Hart? Okay. Julie? Good afternoon. And if you want to sit down, you got a really long presentation, so feel free to sit.
Not like we don't have any room, right?
We can even make you honorary member. I mean, heck.
Julie hits the button and then-
The green one?
It's already green.
Already green?
Yes, it's green. All right. So yeah, thank you for the opportunity to share on the status of maternal and child health in Alachua County. I know it's a long presentation. I know there's a lot of data in there. We could have probably done 4 times this amount of data, but at some point you have to cut it off. So what we're gonna do is we're gonna start by reviewing trends. We're gonna talk about our fetal and infant mortality review findings. And Dr. Hart will definitely talk about bereavement services and support after a loss. Healthy Starts, prenatal and infant screening rates, home visiting services, and then achievements over the last few years in regards to maternal and child health, and then what the strategic plan is for the Healthy Start Coalition, so you can see what our objectives are for the next year. So we're going to start by looking at the birth rate and interpregnancy intervals. And for those of you who are not sure what interpregnancy interval is, it's the time between pregnancies, basically, or births. So Less than 18 months between pregnancies is bad. That's not good. So we want a longer span in between there. And we'll talk a little bit more about the reasons why that's not a good thing. So if we're just looking at our birth rates in Alachua County, what do you want me to like look at you? How do you want me to tell you? Just okay. So if we're looking at birth rates for both Alachua and the state, they have decreased. We are pretty much all this data is looking at 11 years. We're 2012 to 2022. And then over the last 5 years, Alachua has been lower than the state. Florida started to increase in their birth rates in 2020, while Alachua continues to decrease. So one thing you'll notice just for every slide kind of here out, we're going to have a line graph that'll show a comparison from Alachua to Florida, as well as the map that shows our surrounding counties. I think it's really important to see where Alachua falls in comparison to the counties that surround us, to give you some idea of what's happening, because those surrounding counties impact Alachua County as well. If we go to the next slide, births to mothers ages 15 to 17, there has been a decline in those birth rates. And in 2022, the rate was lower than the state. And you can see there's a few years between then that it is also lower. We didn't include births to mothers 14 and younger because the numbers are so small. In the last 3 years, there were 2 births under 14 and younger. So again, I didn't include it because of that reason. And you can see Alachua compared to the surrounding counties is in the lower range there. If we move on to births mothers ages 18 to 19, again, we see the birth rates declining for Alachua and the state. And Alachua had a rate of 9.4, which is significantly lower than the state's rate of 26 per 1,000 and is lower than the surrounding counties. Take yours. Then if we jump to what we consider advanced maternal age or births to mothers ages 35 to 50, we're seeing a steady increase. And Alachua County remains higher than the state. It's also higher than the surrounding counties. So this is one of the few where you'll see Alachua as the green, the darkest of the green, and then the surrounding counties being lighter.
Isn't that good?
Not
Okay.
necessarily.
So 35, that's when they're called geriatric.
Geriatric, right.
Okay. Yeah.
A totally offensive term for
No
those
kidding.
who have been in that.
Yeah.
Agreed. Agreed. The next slide is interpregnancy interval less than 18 months. So again, it's really important to look at this because the impact that it can have on pregnancy and birth outcomes, a person's body may not have had time to heal completely after their last pregnancy. And we also know that there's a greater risk for abuse and neglect when there are multiple young children in the home. So this data is looking at the percent of births that occurred within 18 months of each other.
Julie, does the information, do you glean out whether or not they were planned or not planned? Because I know that my son and his wife, they have kids pretty close together, and they were planned.
Yes. So typically we notice that if they start when they're in the older
Yeah.
range, that the pregnancy interval tends to be closer together.
Right.
For that reason.
Okay, so
They are planned, but the majority that are under 35 are not planned.
so as you look at this data, wouldn't it be helpful to know whether, and I don't know that you can ask the question, whether this was intentional or unintentional? Because, if it was intentional, there's not much that we should do.
Yeah.
I would imagine, unless you present the information that here's why we don't think that it's such a good idea, as opposed to where it's not planned.
And that's the point. I mean, I don't know that everybody knows that it's not okay and what the risks are of having births that close together. I think if more people understood the risks, they may choose not to, and some may still choose to. But I don't think everybody is aware of those risks.
Okay. It would be helpful, and I don't know that you can get that information to find out whether in some of these instances, whether it was intentional or it just happened.
Yeah, unfortunately, the way that Florida Charts has the data, I have not found that or seen that on there, whether it's intentional or not. We may be able to do something with like our FEMA or local, home visiting programs looking into it, but on Florida Charts data, they don't include intention of pregnancy. But it doesn't it's not the inter-pregnancy interval with intendedness.
Yeah,
It's-
it's only gonna be specific to the cases that
We just know if the pregnancy was intended.
Okay.
But of those that had pregnancies within 18 months or births within 18 months of each other, I don't know where to
And
get
the-
intended.
The reason I'm harping on it, Julie, is, you know, the intent of what we're trying to do is, you know, certain areas we want the numbers to go down, others we want to go up. And, you know, whether or not, okay, it's a number, but there's an explanation, you know, so in a few years, when we have to go back, re-up, you know, that we can demonstrate to people, you know, that
Yeah.
the data that, you know, we've collected shows that it's been positive or negative. But most of the data in some of these instances looks like it's going in the right direction since 2019. So,
Yeah, and when we do look at the femur data, you'll see a lot of the losses are unintended pregnancies, so.
okay, thank you.
All right, that is for the births. If we move on to healthcare access and looking at first trimester entry into prenatal care. So since 2015, first trimester entry into prenatal care for Alachua has been higher than the state, which is great. But we still have more than 20% of our mothers who are not accessing prenatal care in the first trimester. And as you can see from the map, it looks like Alachua is doing fairly well compared to our surrounding counties, and many of our surrounding counties are considered maternity deserts. Many of these counties don't even have a prenatal care provider, and if they do, it's severely limited. They're coming one day a week for a few hours, or they're having to come into Alachua County for care.
Are the health departments still not allowed to provide any OBGYN maternal?
The health departments are not providing unless you have some like Bradford and Union through their FQHC that may contract with MIC, but typically the county health department itself is not. Yeah. If we move on to second trimester entry into prenatal care, Alachua hasn't changed much. We're seeing an increase for the state. And again, as you can see, the rates are much higher in our surrounding counties for that second trimester entry. So less are getting it in their first trimester, and we're going to see even higher rates when we get to third and no prenatal care. So if you move on to third trimester entry into prenatal care, from 2013 to 2019, we saw an increase in the percent of women accessing prenatal care in the third trimester, and Alachua was above the state. And since 2019, Alachua has decreased and the state has increased. Again, you can see how high the rates are for our surrounding counties for that third trimester entry into prenatal care.
But if we're beating it, we're pretty high on first trimester.
Yep.
So you would kind of expect us to start dropping, wouldn't you, for first entry and during second and third? So that's not necessarily bad.
No.
Okay.
Nope.
I
that's
just
better.
want to make sure I'm reading it
Yes,
right.
Yep, we want it to be not as high there.
And these
More
are,
in the first
these are
trimester.
percentages?
Percentages,
Okay.
correct. But what we don't want to see is if you go to the last or the next slide on no prenatal care. Alachua's rates of no prenatal care are lower than the state and lower than the surrounding counties, but we're seeing that they're increasing. So, and they're increasing disproportionately. And I don't have this data on there, but the rate in 2022 for white is 1.9 and for black it's 3.1. So we wanted to understand more about access to prenatal care in our service area. So we brought on an MPH student who conducted a survey of the prenatal care providers in the 12 counties, because a lot of the Alachua providers also serve the surrounding counties. And then we're also conducting interviews with some prenatal care providers, and some of the challenges and barriers that they have noted in regards to accessing prenatal care for their patients is no insurance or being underinsured, the access to Medicaid, the location of the prenatal care providers, transportation, childcare, and availability of appointments. And in regards to availability of appointments, they're not available for weeks or months out, but then they're also not available at convenient times for their patients, such as the evenings or weekends when they are not at work. If you go on to emergency Medicaid coverage, so now we're going to look at births and deliveries. The births covered by emergency Medicaid as a payment to the hospital for labor and delivery services for mothers with no insurance or who are otherwise not eligible is what that stands for. And the percent covered by emergency Medicaid in Alachua is much lower than the state at 0.8% compared to 2.8.
Okay, so what does that mean? That,
We have less, my brain is, undocumented, thank you, I was trying to say non-citizens, undocumented, that emergency Medicaid is paying for in Alachua County as compared to the state.
okay. Right.
You said we have fewer undocumented.
Whose births are being covered by emergency Medicaid, right? Because they don't have Medicaid, they don't have private insurance. So emergency Medicaid covers their delivery.
So what about, citizens? Are we saying that, how does,
Emergency Medicaid wouldn't cover them. Medicaid would, if you go to the next slide. So emergency Medicaid covers for 45 days. It's to help pay for the cost to the hospital. Medicaid, on the next slide, is also lower than the state, and both are slightly decreasing. Alachua is also significantly lower than our surrounding counties when we look at the percent of births covered by Medicaid. One of our surrounding counties, Dixie, has the highest percentage of births covered by Medicaid in the entire state at 82.88%. And then if we move on to self-pay delivery payment, similar to emergency Medicaid and Medicaid, self-pay for delivery in Alachua is lower than the state.
Okay,
So that means the majority of our births are covered by private insurance.
so self-pay means they're paying for it themselves?
Out of pocket, yes, not insurance.
Okay, so the Medicaid in the spectrum of, do we want it lower or higher? What,
You would want it lower because that means you have more people who have
Private
private
insurance.
insurance that are working.
okay,
That
The
don't meet
Medicaid-
the eligibility for the Medicaid.
well, people with Medicaid aren't necessarily not working, right?
Right.
So,
Their income is
They're
not
just
high
not-
enough to, or their insurer, their company where they work, their employer does not provide, but yet their
Is what Medicaid provides
income is.
not comparable to what the regular insurance does?
It is.
Okay.
That's great. Actually,
the
they've
fact
got a
that they
lot of
have-
benefits, and I think a big part of Medicaid is they have a lot of incentives and additional programs that the enrollees are not aware of. And so that's something else we try to do is make sure that they understand all of the benefits of their Medicaid plan.
Okay,
All right.
thank you.
No problem. If we move on and we look at maternal mortality or maternal morbidity and mortality, first, we're going to look at mortality. So we've had 6 maternal deaths in the last 10 years. In 2013, well, we've had a total of 3 Black deaths, 2 white, and 1 other. In 2013, the mother was Black. In 2014, 1 was white, 1 was Black. In 2015, she was Black. 2018, white, and in 2022, other. So that is the breakdown. Now, the rate is per 100,000 when we look at maternal deaths. And because our numbers are so low, you see kind of those spikes up and down compared to the state.
Okay, so can you give an example of what happens for maternal death?
Help me understand.
I mean, is it the child born with the umbilical cord wrapped around the neck?
Mom died.
Oh, the mom died. Oh,
This is a maternal death. This is
Oh.
where mom died.
Okay.
Typically preeclampsia
Okay.
is what we see the most of. It could have also been overdose. It could have been, yeah.
all right,
So yeah, right now we're looking at mom, not baby
Okay.
at this point.
thank you.
Of course. If you go to the next slide, maternal deaths by zip code. So we wanted to see over the last 5 years, the 2, and again, in 2018, mother's race was listed as white. In 2022, mother's race was listed at other. The 1 death was in 32609 and the other was in 32669. If we move on to severe maternal morbidity, so again, not mortality, but morbidity, this is the presence of complications during a pregnancy or during the delivery where they're hospitalized for these complications and can lead to negative outcomes for the woman and the infant. So again, mother's health not only impacts her, but her infant. And the Alachua's rate of severe maternal morbidity is increasing, but is lower than the state and the surrounding counties. Again, we do see a disparity there. In 2022, and I apologize for not having this data on the slide, for white, it was 10.1 and Black 24.8. And then Hispanic was actually lower than non-Hispanic in their rates for severe maternal morbidity. Other maternal morbidity issues that we look at,
Oh, I'm sorry. Yes, Dr. Hart.
Yeah, I just wanted to add something that most people don't think about. We have such good tertiary care here and really good rescues of moms in our hospitals that we may have a lot of morbidity and not so much mortality. Whereas in a rural area, they may have more mortality per morbidity because they don't have the ability to rescue the moms that we do here.
Thank you, Dr. Hart. Yeah, I participate on the state's maternal mortality review committee, and that is often what we see is those that are living further away have poorer outcomes when they are having complications after pregnancy, and after birth. So that is an issue, is location compared to, and the level of the maternity department, of the hospital.
If
All right.
there is a hospital.
If there is a hospital, but wherever they're going, the closest one, yes. That is, yeah, that's a scary thing.
If Dixie County, it's coming here.
The only hospitals in our 12 county service area are in Alachua and Marion County. So Dixie, Gilchrist, Levy, Putnam, Suwanee, Lafayette, Columbia, Hamilton, they don't have a delivery facility. They're all coming here. So if there's an issue,
Wow.
we, I know the nurses shared a story that through our Nurse Family Partnership Program where the Dixie County EMS had to pick up a mom who had overdosed, and they had enough time from the drive from her home to the hospital to call our Nurse Family Partnership Program and make a referral in the ambulance. Like, that's how far they had to go and what they were able to
Even
do.
booking it from Dixie County, it's a good 45, 50 minutes to get.
Yeah, that's how I was behind an ambulance today. I got hung up in a whole bunch of traffic.
So you're just sucking right behind them, huh?
I should have. I didn't think about doing that, you know? Oh, it's congested coming along there.
So some of the morbidity or things that contribute to morbidity, smoking during pregnancy. We know that the percent of mothers who smoke during pregnancy, we can see there has continued to decline, and Alachua is still slightly higher than the state. Our surrounding counties, very high. You can see those in the darkest green. And then the next slide looks at weight. So overweight at time of pregnancy, births to mothers, again, who are overweight at time of pregnancy, occurred is staying about the same, and Alachua is slightly lower than the state. However, we go to obese at time of pregnancy. It's increasing and is higher than the state. That we don't want to see. It's at 30.6 and the state's at 29.5. So all of those things, again, contribute to maternal outcomes and infant outcomes. The next set of data looks at economic stability and educational attainment and support systems. So we are always interested to see if father is acknowledged on the birth certificate, and we see that that percentage is increasing. There was a bit of a drop in 2020, and Alachua remains lower than the state. And if you go to the next slide where we look at births to unwed mothers, we see a jump in 2020. So there's probably, you know, a correlation there or association there of COVID was happening at that time. People didn't have a lot to do. We had less fathers on the birth certificate, less births to unwed mothers. So you can see that it's been decreasing since then. And in the births to unwed mothers is in that lower grouping for the state. The percent of families with female householders that are below poverty level with children under the age of 4 has decreased from 49.9% in 2012 to 38.8% in 2022. And on the next slide, the children, similarly, the percent of children 4 and younger living below the poverty level has decreased from 25.2% in 2012 to 18.8%.
Julie, can I go back to the unwed thing? Do y'all drill down to find out whether they're in a, you know, whether they're just not married? And, you know, they're not unwed, but they're still living with their partner?
We do ask about that.
Okay, so these are truly unwed, okay, no partner,
Correct.
okay, thank you.
When we do our intake with the mothers, we ask if they are married. If it says on the screen that they're not married, we ask if they have a support system. Who is that support system? So then that helps us determine what kind of, you know, support we can provide.
Okay, thank you.
So I have a question based on what Lee just asked. So I was thinking unwed is you're not married. Are you all considering this unwed to mean that they're not living with a partner?
But they're unwed, they're not married.
Okay.
But they could have a partner in the home.
Yes.
Okay.
They're
So
unwed.
they're just not married.
They're indicating on the birth certificate that they are not married.
Okay.
Okay, so that goes back to the point that I was trying to make. Are, how many of those, of that percentage are really in a relationship where they do have?
Have that on the birth certificate. The birth certificate doesn't ask that. When we get them, we ask that is what I was saying.
Right.
We ask if it indicates on the birth certificate or on the screen that you are unwed, do you have a support system?
But that's not what this was showing.
No,
us.
that's not, yeah, that's why I was asking the question, because I was trying to figure out like the link between that. Lee seemed like yeah.
That you drill down to where I was trying to get.
Well, and if I look at this data, if you look at the unwed and then ahead of that one, the father on the birth certificate, what it says to me, just looking at those two, is that the number of unwed is now kind of back to where it had been generally, except for that blip in
Mhm.
2020. But there are more moms just having the baby and not including a dad. I mean, I'm assuming that if they don't list the father, they're not married. Likely.
Or they weren't asked.
Really?
Say that again.
Really?
Or they
But
weren't asked.
Not asked?
That's one of the things that we've talked about in our office, where, you know, they may not have asked the father to sign the birth certificate.
Oh, so the mom can't just name the father. It has to be the father has to also sign on a birth certificate to appear on it? Oh, didn't know that. Okay.
If you're
That's
married, is that automatic?
No,
interesting.
for everybody.
Interesting.
That's the other thing that we talked about in our office. It's not for everyone. We see that there is some equity issues when it comes down to that, where so you could be married and the father does not sign your birth certificate. You weren't asked. You could be unmarried and the father, it hasn't signed your birth certificate. So this bit of data can actually, it can be wrapped around some equity issues. Whether or not that's that case here, we won't know unless you dig it a little deeper. But that is one of the things that we talked about, that very much exists.
So the equity issue is what?
I could
don't
be
wanna make
black
this
and
stuff-
nobody and married and nobody, and my husband has not signed my birth certificate.
Because no one asked.
Nobody asked.
So the asking is the equity issue is what you're saying. the
The
inequity.
asking is an equity issue.
I'm just
Especially
trying,
if-
I'm just trying to,
especially
I'm
if
trying to
a
define it. I'm
first-time
trying to figure it
mom,
out.
And I don't know that these things need to happen. Nobody's
Right.
told me.
It's one of those things that's where the women of color almost sounds like are being treated differently. It's kind of adding to that pile of junk.
You got it.
I like the.
Yeah, it's not a good pile either.
No,
It's
it's not a
junk.
good
It's not a good pile. And I guess for me, I was trying to like correlate what Lee was, where he was going, because the scale for fathers on the birth certificate is different from the scale.
And that's what I was
for-
trying to,
For unwed mothers, and I'm a little
yeah, and that's where I was struggling too, because they're like, what is that telling us?
yeah.
Yeah.
Because the reason, because sometimes you think the unwed mother is a potential issue. But, you know, there are some instances when it's not, you know, so, you know, it'd be nice to drill down. What's the percentage of where it's an issue as opposed to,
You gotta
you know,
understand what the source of this data is. This is coming off of Florida charts, which is really based on a very limited set of information that they can gather. They're not asking those, oh, why not kinds of questions. They're just, is it, isn't it?
This is a birth certificate clerk that's entering it to maybe entering it correctly. We see a lot of errors in the data entry. One of the FPQC initiatives is to help try to improve the accuracy of the birth certificate data because they're finding a lot of it is not.
okay, so Marcia, as we go through this process, we're using this data, but what we really need to do is glean what is an issue and what is probably, you know, where we need to focus, you know, based upon, is this really an issue or is it not as big an issue as it looks like?
Right.
So, you know, I know that's a burden for y'all to try to figure out, but
I think there's enough issues that.
But, anyway. You want to continue?
I think we were on slide 28.
Oh, Ken, I'm sorry, Ken's got his hand up. Ken,
Thanks, Lee. Yeah, so all in all, it looks like a lot of these numbers are going in the right direction. On this particular point, I just want to reiterate kind of what I've heard my colleagues say. I'm more interested in seeing that we have fathers on the birth certificate, presuming that they are going to be involved or are involved, than I am whether or not they're wed or not. So I don't know if that is that data is available, but that to me seems to be more important.
thanks, Ken.
Right, so there has been a decrease in the percentage of the population with food insecurity for Alachua and the state, but Alachua was higher than the state and is closing that gap. This is for the entire population. I wasn't able just to pull like pregnant moms or families with young children. We look at no high school education, so the percentage of mothers without a high school education that are 19 and older, it continues to decrease, and Alachua is lower than the state. Again, moving in the right direction there. Next, if we look at unintentional injuries, so now we're getting more to the infant side of things. The first tables on there have to do with non-fatal visits and hospitalizations. So we're looking at non-fatal ED visits. Unintentional falls has the highest number, followed by motor vehicle and poisoning. And if we look at non-fatal hospitalizations, unintentional injuries has the highest number, followed by unintentional falls and poisonings. And the numbers for each have been decreasing.
Okay, what's the definition of unintentional fall or unintentional injury?
Unintentional fall would be where they potentially fell downstairs, fell off of something, they fell down and got hurt. Off the counter, maybe they were sitting up there, fell out of their high chair. Unintentional injuries is kind of an all-encompassing of everything else that's not a fall. So it could be car accident, it could be getting hit by something, cut by something.
As opposed
Not
to
abuse.
child abuse.
Not abuse.
Right, that's.
Right.
Okay, thank you. I know I'm being a pain, Julie, I apologize.
Yeah, I like the questions. All right, low birth weight and preterm births. The first slide on there, thank you. The low birth weight rates are slightly increasing and are higher than the state. So we are at 10.3 and the state is at 9.1.
Okay, and why do you have a low birth weight child?
The health of that child, the complications, there's so many things that contribute to low birth weight. It's hard to it's mom's health, it's her exposure to things during pregnancy. It's primarily stuff that happens during the pregnancy or her health prior to.
Okay, so that goes to, is there something that we as an organization can do something about? I mean, that's what I'm looking at this information, so, maybe me and company can see if there's something that we can do. Thank you.
Looking at low birth weight by race, the percentage of Black low birth weight births in Alachua County is more than twice the rate of white low birth weight births and is higher than the Black low birth weight births for the state. So you can see it's 17.3 for Alachua and 14.7 for the state.
Now, is this something where the 18-month comes into play necessarily?
If you have a pregnancy within 18 months, it could contribute to being low birth weight. Your body isn't necessarily healed from the last pregnancy. But that's not solely.
Okay.
Can you hear us?
She has her hand up.
She does, but I don't think they can hear us yet.
Yeah, I can hear.
Okay, Dr. Hart,
I can, I can hear you now.
Dr. Hart, you have your hand up?
Yeah, are we still on the low birth weight births chart?
Yes.
Yes.
Okay, so I'm just really struck by a couple of things here. One is, first of all, we're very interested in low birth weight births because counting infant mortality is a kind of a blunt measure of what's going on with mothers and babies. So in other words, we're pretty good at keeping tiny babies alive in this county. So we really need to look at low birth weight births rather than infant mortality, in my opinion, in my experience. So I'm really interested in this chart that Julie made for us, because if you look at what's going on in white women in Alachua County, everybody's pretty much acting like white women in the state. So white women equal white women, but the Black women are not only suffering a lot more low birth weight births than the white women in Alachua County and in the state. They're even higher than the state. And in my opinion, low birth weight births are a surrogate for stress of those women. And I think what we're seeing is for Black women in Alachua County, the low birth weight birth rate has gone up. Everything's kind of flat for the white women. And I think we need to really carefully think about what is so stressful for these women who are Black in our county. And I have a few hypotheses, but I'd love to hear what you think. But I think this is the gap. This is the most important gap that I've seen so far that we need to think about as a trust.
Thank you.
Dr. Hart, did you hear our discussion earlier? Like about frontline, we were talking about the Alice families. I mentioned about the data that we heard around, the United Way shared their most recent Alice data with us.
No, because sorry, that's when we lost our audio.
Lost
I was
audio,
watching your
yeah.
lips move. I'm sorry, I don't read lips terribly well.
Okay, Julie.
Mr. Chair,
Oh, I'm sorry, Christy.
one quick, I was wondering, Julie, if you have any additional causes that you can mention with the low birth weight for African American women as you're looking at your data. What can you share with us here today?
Mother's health at time of pregnancy is what we see.
So it's preconception health, in between pregnancy health.
Both, it's preconception health and leading up to that time of pregnancy. So that could be interconceptionally or if it's their first pregnancy.
Anything else?
High blood pressure. I mean, that's all that, mom's
health.
health. That's the big thing that we see. Those perinatal periods.
And access if you're getting
Wow. I had a stressful period, boom,
It's poverty.
high blood pressure. And the doctor said you
It's
can. hang it up.
poverty.
So
It's not having access to healthcare. It's not being able to have Medicaid because you're a single woman until you're not. And then you only get, covered when you're pregnant, and it's the stress of, we can talk about all of these, but the common thread is poor people. And the poverty rate for Black folk in this community is much higher than for others. So. yeah.
yeah, please,
Nancy, Dr. Hart.
Yeah, so not to throw another monkey wrench into the works, but I really think we need to look at stability of housing for pregnant women and women who are raising small children. I think housing is an issue that I was totally clueless about the whole time I practiced high-risk obstetrics, and now it's finally come to me that the medical things that we can control in the hospital and in our prenatal clinics don't touch these housing issues, the housing insecurity. So I want to bring that to everyone's attention.
Yeah.
Thank you.
Social determinants of health, transportation, food,
Poverty.
Poverty.
That's what we talked about when we lost sound about here, about the housing insecurity, the daycare, all the expenses of folks that's teetering on the edge.
And it's also especially not being quite poor enough.
Right, the teetering on the edge, yeah, you know?
That's the Alice.
Yeah, it's that Alice group that's, yeah.
Okay, very low weight.
Very low birth weight. Since 2012, the percentage of very low birth weight in births in Alachua has decreased to 2.2. Or from 2.2 to 1.6, sorry, but you see that spike there in 2018. We're not quite sure what contributed to that spike. And if we look on the next
It
slide,
was Black women who contributed to that spike. Or no, it was actually white women who contributed to that one, wow. Is it very low?
no, it's black.
isn't
It
Oh,
is
yeah, the cream is black. Okay, I'm sorry. I was
5.1.
back to- Yeah, thank you.
Yeah.
Yeah, it was, that's what contributed to the spike. Black women having very, very low birth weight children in that year.
Yeah. If we look at preterm births, we're gonna see similar to the low birth weight. So the percentage is slightly higher than the state and has been increasing. And according to the March of Dimes every year, the March of Dimes puts out a preterm birth report card. Florida, which has the rate of 10.5%, is a grade of D, and Alachua's grade is an F because its percentage of births is greater than 11.5%. So that's pretty much the worst grade that you can get. And then again, preterm births in Alachua. So for Black, it's 60% higher than our white preterm birth percentage. And is higher than the state. We move on to look at fetal and infant deaths. So we'll start with fetal deaths. The fetal death rate for Alachua in 2022 was 5.2 per 1,000 deliveries. This is lower than our surrounding counties. But the map there, I'm going to show you two different maps. This one is the census tract, and the red is the highest and the green areas are the lowest. I know that's kind of hard to really identify different parts of Alachua County. So one of the reasons why you had an updated presentation is we wanted to provide it by zip code. So the next slide has the fetal deaths by zip code plus the count. So you can see where those occur. Give you a minute to look at that. So green means there were 0 in that zip code. 1 or yellow is 1, orange is 2 to 5, and then red is 7 to 19.
And fetal deaths, I think you said it was before delivery.
Correct.
Okay.
Yeah.
So, Dr. Hart, thank you.
Yeah, a quick question for Julie. These quartiles are state quartiles or is it our county quartile?
It's the county.
Okay, so fourth quartile is bad.
Yes.
Got it.
Yes. And there were, again, apologize for not having this data on there. The more I looked at this, the more I wanted to keep adding to it. During that 5-year period of 2018 to 2022, 34 of those fetal deaths were white, that's 38%. 47 were Black, which is 53%. And then 8 were other or unknown, and that was 9% of the 89 total fetal deaths.
So if I'm not mistaken, if I'm looking at this by zip code, 3260708 is SWAG. 32609 is Library Partnership. And 32641 is where there is the, so we have family resource centers in each of the worst areas for this, right?
Yes, because we now have.
4-1 is partnership, right?
Is that 4-1?
Library Partnership, Northeast.
4-1 would now be the one community. Is that the East Gainesville?
Yeah, because Cone Park is closed.
That,
But yes.
But it's that, the
Yes.
one that took over for Cone.
Correct.
Okay. So at least 3 of these have partnership, family resource centers that
that we're funding.
Mm-hmm.
Well, which presents an opportunity
Right.
to do some focused kinds of things. There, to me, as point earlier, Tina, before you got here, I was asking about the outplaced person at the different OBGYN clinics, and turns out we only have one. And so the question is, are there opportunities
Mm-hmm.
to better reach? And it seems like,
Yeah.
to your point earlier, that could be, it would just depend on how, there's now going to be that mobile, the mobile maternity clinic. And to my point, a concern earlier about there are points of opportunity some points of opportunity are better than others. And if that clinic were to hit these sites, and we could then, that's the point of contact when that's happening, so is our person. Seems like it's a good opportunity to start to get to some of these women and
Mm-hmm.
You know, so do y'all determine, is the data available whether they were preventable? Some of these deaths?
On charts, you can't pull that. We could find that out by doing the fetal reviews in FEMA. We look at that. Preventability, that's one of the questions that we ask.
That would seem important. Okay.
Right, so the next two slides are looking at the similar data that you've already reviewed, but 3-year rolling averages, just to see more of a stable trend. Not really much more to say there than what we've already talked about. There was a spike in 2021, we think could have been COVID related, but don't know that for certain. Then if we look at infant mortality, in 2022, the infant mortality rate was the lowest it's been at 6.7 per 1,000 live births, but still remains slightly above the state. On the next slide, we have again the census tract and the rate for Alachua County at 8.8, and you can see where that falls within, in regards to the surrounding counties, so in that highest quartile. The next.
I had a question. The infant mortality, like for Alachua County, it seems so much higher than what the state is. And is that because of the 12 counties? And you mentioned that none of those counties around us have maternity wards, that they're all coming into Gainesville. So if someone dies, they're reported into Alachua County statistics.
They're not reported into Alachua County. It's by their county of residence. So if they live in Gilchrist County, but die in Alachua, yeah, it would be counted for Gilchrist County, not Alachua. So it's county of residence.
So is there,
we own these.
Yeah, that's a lot considering. Ooh.
Mm-hmm.
so is any of that where some of the data is dumped on Alachua County if there is something undetermined?
It's reported on their county of residence.
Okay.
If you pulled hospital data, it's going to include surrounding counties unless they pulled Alachua only residents, but the Florida charts by county of residence.
Okay.
So again, we've looked at it by zip code. The 3 or 4 highest there, 32606, 607, 608, and 609, followed by 32615 and 32641. There were, for the breakdown light, there were 48, which is 38%. Black, there were 58. Again, this is in the 5-year period. 58, which was 46%. And then other and unknown, there were 20, which was about 15%.
Kind of a correlation between the infant and the fetal.
It is interesting, just in general, that Alachua has a similar number of fetal and infant deaths. Our surrounding counties, we see either much higher on the fetal side or much higher on the infant side, but Alachua is pretty similar on both the number. So the next slide looks at the 3-year rolling average by race. And again, we can see there that the Black infant mortality rates are twice the white infant mortality rates and higher than the state. If we break it down by the neonatal and the post-neonatal period, so the neonatal mortality are infant deaths that occur in the first 27 days of birth. And similar to the infant mortality rates, the neonatal mortality rate is the lowest it's been, but is slightly higher than the state's rate. And so these deaths are associated with events that occur during the prenatal period, and most of the deaths occur due to preterm birth complications or intrapartum related events. So some of those leading causes: low birth weight, congenital malformations, maternal complications, placenta, cord, and membrane complications, bacterial sepsis, birth asphyxia, and severe infections. So they're more on the medical stuff
Mhm.
when you're looking at the first 27 days. Post-neonatal are the infant deaths that occur between 28 and 364 days of births. These are deaths that are more likely to be related to conditions or events that happen after birth, like SIDS or unintentional injuries, homicide, and then diseases of the circulatory system and renal failure. And over the last few years, Alajua's rates are similar to the state's rate, with a spike in 2019. If we look at the post-neonatal mortality by race, there's an increase in the Black post-neonatal mortality rate. And what we're seeing is it's due to the perinatal period conditions such as maternal conditions like hypertension, maternal disease, and then maternal complications of pregnancy and complications of the placenta, cord, and membranes. And I think that's what you were asking about as well, Christy. Like, those are the things that we're really seeing impacting those outcomes. If we move on to the causes of death under the age of 1, so the number of SUIDS deaths, which SUIDS is the unexpected infant deaths, it's continued to decrease since 2017, and we had no SUIDS deaths in 2022. SUIDS includes like SIDS, which are unexplained, and sleep-related deaths. So that's great that we didn't have any in 2022. Where we see the perinatal period conditions has also been decreasing, and congenital malformations increases and decreases over time. There's not really a trend there. I know that one's kind of a lot to take in, so let me know if you have any questions. On the next slide, infant deaths from SUIDS.
Julie, I'm sorry, I think slowly. Going back to what we're trying to do here, there's certain things like the congenital malformations and chromosomal abnormalities. There's not much that the children's trust can do. Now, the perinatal period conditions and the SUIDS, that's information, but explain the perinatal period.
Mom's health
Condition.
Okay. All right. Okay. That's something that perhaps we can do something about, so.
Before she starts having babies. Infant deaths from SUIDS. So this graph shows the decrease of SUIDS deaths.
You said something just there.
Yeah.
There's, if it's someone who's 18 or under, yes, we can do something about that. Now, if they're not 18 or maybe if they have a child, even then 18 or under, but if they have a child in there, there might be something that we can do about health. But if it's just before they have a child and they're over 18, there's not much we can do about that.
No, not with this money. Not with this money. We need that
Right.
Medicaid expansion money.
Yeah.
That's what we need in Florida. We need that Medicaid expansion money.
So to that point, if we can distinguish some where we can focus, then that would be good. So.
Well, the next slide, actually, we're excited to share is the decrease in SUIDS deaths. You can see 2016, 2017 is when we had kind of our highest peak there. We started newborn in 2018. And in 2022, we had 0 SUIDS deaths, no sleep-related, no unexplained death.
That's Dr. Hart's this side up t-shirt.
Yes. All right, now we can look a little bit at our fetal and infant mortality reviews. if you go to the next slide there, we launched the Healthy Start of North Central Florida Fetal and Infant Mortality Review Program in February of 2023. So we finished our first full year in June of 2024. The program includes 12 counties. So this is not Alachua only. Our coalition service area is 12 counties, does include Alachua. And we're contracted to review 36 records annually, and 4 of those based on the methodology are to be from Alachua County. However, we were able to review additional cases this year because we weren't able to get some of the records from our smaller counties. So we were able to get 9 records for Alachua, which is great. So we're able to get a little bit more information there. So you can see of those 38, 9 were Alachua. And on the next slide, in the 17 months that we have been conducting FEMR, we have reviewed 7 fetal deaths and 8 infant death cases. So again, we're trying to review cases proportionately to those fetal deaths or the infant deaths. 67% of the cases that were reviewed, the infant or the fetal or infant, the fetus or infant were Black, 27% were white, and 6% were other. This isn't necessarily representative of the actual deaths. It's based on the cases that we were able to get access to. So as much as we try to have our methodology align with what's happening in the county, a lot of it depends on where we can get all of the information and the records from the hospitals, their prenatal care provider, from the state. A lot goes into that. So just for a comparison, about 50% of our fetal and infant deaths were to Black babies, and we reviewed 67% of our records were Black babies. 38% of the deaths are white, and we reviewed 27% of our records that we reviewed were white, and then about 12% are other or unknown, compared to 6% that we were able to review. The next slide. 20% of the cases we reviewed were Hispanic, and 80% were non-Hispanic or unknown. So not all of these could we identify whether or not they were Hispanic. So we just look for anything in the record that may indicate Hispanic. So it could be a higher percentage. It's just 20% we know for sure somewhere in the record indicated that that baby was Hispanic. We look at the family planning. So this goes back to what we were just talking about. Of those cases, 20% were considered grand multigravida, meaning they had more than 4 children. First pregnancy, 20% of them. 13.3 had an interpregnancy interval less than 18 months. 13% were intended pregnancies, and 67% were unintended pregnancies. 87% were not using birth control. When we look at the characteristics of the childbearing parent, 6.7% were considered high income, 33% moderate income, and 60% low income. 40% of those had Medicaid, 13% had a college education, and 73% had a high school diploma or GED, 13% less than high school education. 13% were 35 years of age or older. None were considered late teen pregnancy, and 6.7% were early teen pregnancy, so 17 and under. 40.
How does that compare to previous years? I know you have a staff. I know you said you just started this review last year. Do you have any data on teen pregnancy prior to this?
We don't. This is all of the records that we were able to do since we started. So we don't have a comparison yet. Next year, we'll be able to start looking at those trends to see. 47% lack of partner support, and 80% were unmarried. On the next slide, we look at the health of the childbearing parent. 27% had previous pregnancy complications. So in a prior pregnancy, they had complications. 20% had postpartum depression, 40% anxiety, 33% depression, 6.7% addiction disorder, gestational diabetes. None indicated gestational diabetes in the records. Again, doesn't mean that it wasn't present. It just wasn't indicated in the records that we were able to obtain. 27% had preeclampsia, 20% gestational hypertension. The big one, those medical complications and infection during pregnancy was 73%. Positive for STIs, 53%. Didn't achieve the recommended weight gain. So either they gained too little or too much, was at 53%. And then 40% were overweight or obese.
Question.
Yes, ma'am.
The medical complications, infection during pregnancy, that's something in addition to what we have listed here. Can you give us an example if so?
Shall we? I'll defer to our female coordinator.
Pretty much all in the same.
Or you can stand.
That's encompassing all of the possible complications of medical or STI infections. So that's a little bit of more of a catch-all. So if you're wanting to drill down specific, it's better to look like the specific preeclampsia, gestational diabetes or anything. But this could encompass other different STIs. Sorry, did you have a question?
I was gonna say, is the light green on the?
It is.
Okay. It is working. Nancy, could you hear us? Okay.
Oh, Dr. Hart has her hand up.
Just wanted to make sure.
Yeah. Dr.
I
Hart?
just wanted to make a point that a lot of times when there's fetal and infant mortality, there's premature rupture of membranes. And premature rupture of membranes, a lot of times we try to keep the baby in as long as possible, and then they get infected. So it doesn't necessarily mean that the infection caused the premature rupture of membranes. Sometimes yes, sometimes no. It could be that we were just trying to hold that baby inside and then an infection occurred. So I would expect that would to be the highest medical complication on this list, because it just goes with fetal death and infant death.
Thank you, Dr. Hart.
I wanted to ask a question or clarify, and I want to make sure I understood. Were you saying the infection rate was all encompassing? So am I to the positive for STI, that's also included in the infection rate? Is that what we're saying? Is that what you were saying?
The medical complications and infection during pregnancy, that could include like choreo or some sort of infection that was not an STI related. So the positive for STI is specifically the STIs.
My question is,
Not back to the same question, I
my
think.
question is, are positive for STIs included in that 73.3%? That's
Potentially, yes, that could be duplicative, yes.
okay. Thank you.
Is there some way we can tease that data out better for you? Or is
No,
like,
I was just wondering if we're saying of those 73%, 53.3 were also included in there. So I'm wondering if we factor that out and we say, we take out the 53.3%, and if that's leaving in that 20% range as other infections, or is that something, are they two different metrics is what I'm.
Or they could, because that other one is all inclusive, they're not going to add up. I suspect that
Right.
it could include, someone could have preeclampsia, hypertension, which actually tend to go together. So you're not going to add 26, 20, 53, and that's higher than 73 because a lot of those can co-occur.
Okay.
So you could, when you look at the really specific ones, they can co-occur. But they're not going to be counted twice. They're going to, so it's, if I'm reading this right, that 73% includes women who had any of a great number of possible medical or infectious issues.
that is correct.
So they
Okay.
could have STIs and another infection.
It won't
Yes.
double count in that 73%. It'll just count as a mom who had medical issues. You see what I'm saying?
Mhm.
That's a more of an unduplicated count of mothers with medical issues.
So then it seems. Am I to conclude that if there was an STI, that person would, and that was only an STI, that they would be on the STI line and not in the line?
No,
that
they
has
could be on both.
It could be in both.
They would be on both. That's what I'm saying. The unduplicate, that 73% is anything.
Okay,
The others are specific, which is why they add up to more than 73%, because you can have more than one.
okay. Thank you.
The last slide for fetal and infant death cases reviewed. We looked at entry into prenatal care. 11 or 73% entered in first trimester, 27% or 4 second trimester entry. When we look at adequacy of prenatal care, 60% had 5 or more prenatal visits and 27% had 4 or less prenatal visits. Not sure what we did there. That must be an error because you can't have 0 and 13.3%. So we'll figure that out.
I was getting ready to ask. So,
And
so
maybe
what do you call adequate? Is adequate these percentages here? Is adequate 5 or more
No.
or?
It is not adequate. So there's an index, it's called the Kotelchuk Index. And it's more complicated as far as when they entered into prenatal care and how many visits they had. There's a lot more that goes into it. This is really just kind of breaking it down on how many visits they had based on what we were looking at.
So I think that's kind of misleading.
It is, if 5 or more doesn't necessarily, if they
Okay.
had 5 and they started in their 3rd trimester, that's not adequate prenatal care. The number is not indicative of adequacy.
Well, and given the number of them that had severe medical complications, 5 certainly would not be adequate.
Right, yeah, you would want that in your last month of. And then of the cases reviewed, 93.3% of them were eligible for home visiting programs, but were not participating. Our key takeaways, we have just a few points there. In 20% of the cases reviewed, the childbearing parent smoked during pregnancy. 13% used marijuana during the pregnancy. 63% of the infant cases reviewed, the infant was never breastfed. 27%, the newborn had to stay in the NICU for more than a day. 25%, the infant was in an unsafe sleep location. And 25% objects were found in the infant's sleep environment.
What's objects found, meaning?
Blankets, pillows, stuffed animals, anything. There should be nothing in their sleep area.
Amazing we survived.
Anything.
I have a question. So of these, you said this percentage here, this 93% that weren't participating. I guess you're reviewing the files afterwards, so you have no contact with the mother, correct? To see like what was the hurdle? That's been my question. I've asked you all. We're funding something and we're trying to make sure we have good participation in it. Do you have any feedback or any indication of what would increase participation if we're saying this is?
One of the next step that we would love to be able to do with this is maternal interviews or family interviews, and we haven't been able to implement that piece of it to actually ask them those questions.
That is the next piece that we're actually actively working on, is getting the maternal interviews up and running. We had to kind of learn on the fly while starting the program. So this has been like probably the biggest challenge, is getting the maternal interviews up and running while flying at the same time.
And building,
flying, operating. Yes.
Have you all, I mean, I think I'm not a medical provider. Preface that, say that out there. But I will say, my question is have you all diversified your workforce so that you have people that work in your program that look like that are diverse, that look like our community, so that there may not be that hindrance to communicating and inviting a stranger into their home or their personal environment, so that information could be, taken, and that they may feel that will be negatively used against them.
And just to give you a little context, so the pieces of FEMA include 2 parts. There's the case review team as well as the community action group. Both are not just FEMA staff. We just keep things running. It is a community-driven program, both pieces are. So we actively recruit and constantly are looking for new membership from all different walks of life, all different fields. We have a very diverse community action group as well as a case review team. We have 2 nurses that do the abstractions with us. We don't all look alike. We all definitely come from different points of view, but that's what the point of the community action group and the CRT is for, is to have discipline, multi-views at the table looking at these cases.
So
yes, the staff that we hire for the home visiting programs should represent the community that we are serving.
it should, do they? I'm asking. And I was asking about the newborn for the home visiting services. I'm asking.
Within capabilities, yes.
When you say within your capabilities.
Who applies for our positions, who has the qualifications for the positions.
Do you do any active recruitment if someone if there's an underrepresented status or race or sex? I mean, we know most of them are women. Are you actively recruiting in spaces if folks are not applying? Because, you may throw something out there and they're not necessarily going. You may have to go and take the bowl of water and say, here, we're here. Come drink from us, drink with us. You know, I mean,
Associations, the schools, we post it on social media, we pass it out to all of our community partners.
I only ask because we can have the best programs in the world and put a lot of money towards them. But if the intended population is not partaking, it's only benefiting the employees, you all. It's not benefiting our community. And so I don't mean to beat a dead horse every year, but this is really important to me, just like it's important to Dr. Hart and to Lee and everyone that we get to the root of it. We have to engage with the community on a number of fronts. Programming is one, but if folks have no trust or for whatever reason that they're not engaging with the program and taking the services, to me, it's all for naught. It won't reflect itself in positive outcomes. We will be spending good money, but if we're not getting a positive outcomes and return on that, I think we have to reevaluate how we're doing that. That's the only reason why I'm doing that. And I have had people to tell me, as I've said to you all, when you've come in the past, is they tell me they don't want people that don't look like them in their household coming into their space because they don't want information that they may share or that they even don't speak used negatively against them. And that's a hurdle that we have to overcome with this program. If we got to figure out some kind of way to be more reflective. And I mean, it's not just you in this, it's also in education. This is my whole thing I say with that. We have to not just say, well, we did this and we did that. So I always have to ask that question because I want us to make sure we are reaching those people who have the greatest need for this and can benefit the most. And we've already expounded upon how poverty is that issue. And we want to make sure that folks feel comfortable to take part in something.
One of our newest initiatives is our doula program, and we were fortunate enough to get funding to train 63 doulas in our service area. 18 of those are from Alachua County. We intentionally identified and selected doulas for free training, the Children's Trust helps support paying for the continuing education and enhanced education and training for them, specific in the zip codes where we were seeing the greatest rates of infant mortality, fetal mortality, maternal morbidity. So not only is it helping build economic stability within those communities, but it's also support for the families. So the intent is to identify individuals in the community that they want to go back and serve that are within their community. So it is a key component to what we do. We understand that impact.
So, one of the lessons that I bring from the mental health and addictions field, sort of to your point, you can have a phenomenal program, but if nobody comes, it doesn't help. And so what we learned often the hard way was that it's what you offer, but also who does the offering, where and when. And I think that's kind of part of what I think we need to really think about. I love the program. I think the program does phenomenal work. And I think this data can be very, very useful. I think that we need to think through carefully that other piece of who does the offering, where they offer it, what the context in which you offer it. And one of the things that we learned, for example, was that when you've just overdosed was actually not a bad time to reach out to you. But that meant, and that the who often was a peer. It may not always be initially the nurse or the master's level clinician who can do the intake and get you into the program. It's hi, I've been there. Are you kind of done with this now? Is it time to make a change in the ER, right? And that took a lot of work because emergency departments didn't even know what a peer was, let alone want to credential them to come into their hospital to talk to somebody at the bedside. But that's what would work. And so I think we need to learn the same thing here. Where do we need to deploy and who do we need to deploy? And at what point in that person's journey do we deploy it so that we have the highest opportunity to engage?
I think along that point, we don't have control at the OB practices in the hospitals of who is offering the screen. Their staff of those practices or of the hospital. And depending on how they present it, to me, they presented it as, this is as the director of Healthy Start. They presented it to me as, this is a state program, you don't need this. So there was a very long conversation after that. So can you imagine, we have one provider liaison going to all the providers in Alachua County, in 12 counties, trying to educate them on what home visiting is, what the benefits of home visiting is, what this screen is, how to properly complete the screen. And then we're relying on them to do that. And then what we get. So having that family partner at the one practice, we've seen huge success in having somebody there, like you're saying, at that time where it's right, where it's somebody they trust, it's part of the practice that they've been involved with. The consent rates are so much higher.
So maybe the hospital isn't the place. Maybe the place is wherever they first are known to be pregnant.
But when we
OB
have our people asking them,
Right, and it's our person, and they say, oh, and by the way, when you get to the hospital, you give them this card and you tell them you want this service.
Okay, we'll continue this conversation after we've done the presentation, when we try to figure out what the next step is. And Dr. Hart, you have your hand raised.
Yeah, I'm just reading this key takeaways, just trying to step back from it a little bit. And this is one time when Tina and I are kind of on the same page, because everything that was selected for these bullet points, except for one thing, is blaming the mom. And I just think that's not the way to look at fetal and infant mortality. You're making a mistake if you think that you can convince the mom not to smoke or not use marijuana or breastfeed, and that's going to reduce fetal and infant mortality. I think what you have to do is deal with her social determinants of health, which are way broader than whether she smokes or uses marijuana or breastfeeds. So I am a little bit worried about what these key takeaways tell us. Maybe we aren't asking the right questions when we interrogate the record or the files.
that's a very good point. We're restricted by what goes in the data system on what data points we can pull out. So those are the things that we have to report on. We fill out, do you want to explain that process is? But what that data that you're looking at up there is specifically what we're required by the state to report. And that's what we're pulling out. But I hear you.
Right. But
with you
we're
at all.
smart people. We're
Yeah.
smart people, Julie. We don't have to just do what the state requires. We can do what's right for our clients.
Yes. Yes, agree.
Okay, let's continue on. So, because we need a little time to figure out, Christy.
Yeah, no, you hit the nail on the head. I was gonna say if we could get through her
Yeah.
presentation, so, because I think I want Mia to have an opportunity to close out and talk a little bit more about some expectations, to kind of support the route that we're going.
I'm trying.
Okay, I know.
Sorry. So the next slide, I was asked specifically to put this in here, I think based on some of the questions that have been coming up. So this has to do, if you go to the next slide, the Florida prenatal and infant risk screen. So 45% of Black and African Americans consent to that screen. Of those, we were able to complete an initial intake on 74%. Once we were able to complete that initial intake, which is basically meeting with them, explaining what home visiting has to offer, 82% accepted. So really the key takeaway here, and of course, there's a million things that we can look at and add to this. It was just one kind of factor that we were looking at, is if we are able to actually speak to the families, that we have a high percentage that are willing to accept a referral, thank you, into home visiting. So again, I know there's a lot that we could talk about here. So and this was going back to that family partner position, we're projected to see 468 pregnant women, 416 have accepted a referral, which is 89%. That's significantly higher than anywhere else that we've been doing it over the phone, the screenings. So I just wanted to share that. The newborn data is the next few slides. Again, I know this is a lot of information on there. I don't know if you want me to go into all of it specifically, because I know we still have a lot to do. But what you see here is in the first table, births by zip code. And then that's going to carry through on the other side. So of the total births, 70% are identified as white or other and 30% as Black. And there were 2,664 births in Alachua County in 2022. If you go to the next slide, intakes completed by zip code. Some of those that have 0, there were no births in that county. It doesn't mean that there were, of the births, none of them consented. So again, we could do a better job, I think, of presenting this data so it's more understandable. I think the key takeaway here is of those that, of the total births, 70 or 69% of those that had an intake, 70% were white, 30% were Black or other. But then if you look in that little box, this is the point I wanted to identify, is of all of the births, 61% of the Black births had an intake, and 58% of the white births had an intake completed. So very similar in those percentages. And then if we look at assessments completed, so again, we're looking at the total overall assessments, about 70% were white and other, 30% were Black. So again, not significantly different than what we're seeing in our distribution of total births. And of those, of all of the Black intakes, 37% had the assessment were Black and 40% were white. So again, we're seeing similar percentages there. Any questions on that? Yes.
Yeah.
I'm explaining what those are.
First.
No.
Okay. Nothing there. You have intakes completed. You have 1,500 completed, but there were 2,600 births. So the 1,100 were, they weren't done, or intakes completed by zip code. It says 488, 61%. Total white, others completed 1,084. Total intakes completed 1,572. There were 2,664 total births. So that means 1,100, there weren't 1,100 intakes.
Yeah. That doesn't seem right, but let me look into that. That doesn't seem right compared to our percentages, what we normally see.
Okay. And so the assessments, same sort of thing.
That's, yeah, that's more accurate for sure. I need to look into the intakes. I might have missed something there, but definitely for the assessments, we're looking at assessments completed. We're looking at about 7. This year, it's a different, we're looking at 741 being completed this year. So what I had to do, the reason it looks odd is I had to split it up into 2 different timeframes because the contract years are different than a calendar year. So it may not be completely comparing apples to apples.
And Julie, I apologize. I'm just trying to understand this process. You did 611 assessments. There were 2,600. You don't do an assessment for everybody. You do an intake. You try to shoot for, say, 100%. And of those, you determine which ones you want to do an assessment.
We offer the assessment to everyone.
Okay.
So at the hospital, the intake is done by the family partner. They offer the newborn home visiting program. The family can accept or decline at that intake. And then if they accept, then we offer the home visit or the assessment.
So an intake is the initial visit and an assessment is a little bit more in-depth.
The intake is done at the hospital,
Okay.
where we ask them about resources, needs, and explain the newborn home visiting program, get their consent to participate.
Okay.
If they consent to participate, then the nurse contacts them to do the assessment.
Okay. So there were 611 out of 2,600
Yes.
births. Okay. Is that?
That was for a time frame between 2022, trying to compare with the births. This year, we're looking at, like I said, 741.
So it's about percentage of assessments done on the birth.
So this year, we will have done 2,036 intakes. That's 88%.
Okay.
So that's why I'm saying I don't think that data is correct.
Okay, but I'm working on the assessments now, and the assessments, what I'm trying to determine is you don't necessarily have to have an assessment. You do the initial evaluation and then y'all determine whether or not there's an assessment.
So 741 divided by the 2,064 births
Okay.
would be your percentage of total births that had an assessment.
Okay, so so what I'm looking for is where does that rank on the scale of need? Is that completing the need, or is there more need for the assessments to be done?
There's more need.
Okay, all right, thank you.
It's a universal program, so there's no criteria to be eligible for the assessment.
Okay, Christy's gonna shoot me if I ask him more questions, so carry on. I don't want to get shot.
All right, so we wanted to look at some recent achievements. Not everything is doom and gloom. A lot of good has been happening in maternal and child health. And I think we get, focused on there is still so much work that needs to be done, but I think we also need to recognize how much work has been done. So we listed, if you go to the next slide, I don't need to read all of these to you. I'm sure you can, look through them and understand what they are. But some of the biggest successes that we're really proud of that have happened in Alachua County in regards to maternal and child health is having a femur, trying to really understand what is happening in, causes with these fetal and infant deaths. And to go back to that, femur is not about placing blame. It's looking about what systems issues there are in the community that can be addressed to improve these outcomes. We were able to implement a fatherhood program. Like I said, we trained 63 doulas, 18 of those were Alachua County. I know about a year and a half ago, I came to you guys because we were really upset that we were losing our nurse family partnership program, which provides services specifically to women who are substance using. Not only were we able to obtain funding for that, but we were able to expand into all 16 counties that we serve with support from the National Service Office because they believed in the work that we were doing and the impact that we had in this area. We are now a designated milk bank depot site. And in the last 2 months, we've collected almost 4,000 ounces of breast milk. 4,000 in 2 months. That's insane. I don't think I produced that in both of my pregnancies together. We have what we call our moving crib display or safe sleep displays. So this sets up what a safe sleep environment is, and they can be moved around. We call it a moving crib display because it can move around the community. It has a pack and play or a crib with nothing in it, no objects, and what the baby should be wearing. Diaper distribution. We've trained our home visitors on perinatal mental health and mental health first aid. We have distributed Narcan kits to all of our home visiting programs. And in fact, last month, our supervisor for our nurse family partnership program was outside of the Hampton Inn downtown. And when she walked out, there was a big group standing in a circle trying to figure out what happened. She went over there and a man had overdosed and was laying on the sidewalk, and she was able to go to her car, got Narcan, administered Narcan before the ambulance even got there. So all of our home visitors are equipped and trained in that. And then with our femur, we've realized too that there is a huge lack of resources and services available to families who have had a loss. So we've been trying to increase the information that we have on our website with regards to bereavement resources, as well as speaking with the prenatal care providers in the hospitals on what they're providing and what they need to adequately support the families in their practice or in their hospital when there is a loss. On the next slide, this is looking at just the home visiting programs under our umbrella. So Connect is that coordinated intake and referral system. That's where all of the prenatal and infants come through. What we call an intake is completed on them. So we identify what risks and assets they have and help identify which home visiting program would best meet their needs.
Just Alachua County.
This is just Alachua County, correct. In Healthy Start, we served 514. Our Team Dad program was new, so we were only able to get 6. We would love a whole lot more. We have an awesome team of coaches with Team Dad, so we're hoping to increase that. Again, this was ending in June 2024. I think we're up to 13 now in Alachua. Parents as Teachers, which focuses on infants and children 0 to age 3. We had 136 families there. Nurse Family Partnership, 56. And then newborn, during that time span, it was 697. And so, oh, sorry.
Paul Butt, the rest of it.
I am. All right. So just so you guys are aware of kind of what the focus is for the Healthy Start Coalition, Again, I'm not going to go through each of these, but what we have to do every year is a needs assessment and a strategic plan. We review it, we update it. So what we focus on has to do with healthy pregnancy, healthy birth, healthy baby, and then healthy family. And within those, we have strategies to improve those outcomes. So we're looking at reducing stillbirths, improving pre-pregnancy health, access to the doula services, childbirth education, getting families into home visiting, reducing unintentional injuries, increasing breastfeeding, the milk bank depot, just increasing awareness of maternal and child health issues, supporting families with substance use, improving bereavement resources, and then perinatal mental health. The end.
That was impressive. Thank you very much. Yeah. Any questions before Mia, you're going to continue?
Yep, I'm gonna do it in 1 minute, so y'all have time to discuss. So our next steps, you'll start seeing, communication for next steps. So in August and September, we're gonna have community listening sessions and interviews. And we also have Access Task Force meeting. I've said that word a few times, but Access stands for Assembling Community and Clinical Stakeholders for Empowerment and Strengthening Families. And that's being led by the contract we have with UF Maternal Health. And of course, the good part about that task force, it brings all the different parts of our county, different organizations and people who can talk about maternal child health to help us figure out what our next steps are, what do we need to implement in our community, along with looking at alongside, everyone else, what's coming out of our listening sessions and interviews. The good part is that's one of the things that when we talked to Healthy Start earlier on in terms of what we would like to see for this contract year, that was one of those things that we really talked about. And I'm proud to say that was one of Julie's suggestions, and she was able to actually help provide that suggestion to UF Maternal Health for them to kick that off the ground. In addition to that, we talked about social determinants of health, and that's one of the things that UF Maternal Health and Access will be looking at. We talked about the mobile buses. They already have that, so that Access Task Workforce will also be looking at how that's implemented. Are there other things that we need to look at? Out of all the information that we've heard today, hopefully you heard some themes here that, number one, we have some racial equity issues that we definitely need to be able to address in our county. We also have some issues that are right along all certain zip codes as well, with very rich resources in those areas. So to be able to increase those resources and to be able to look at how we can help more families and work alongside them, that's, to me, what we should be doing, number one, and being able to pull in our community folks and our community voices to figure out how best to do that. With that said, we're going to my last slide. I think I said that in more than 1 minute. And I want to know, you've been talking all along. What did you hear? What concerns do you have? You've been writing down the gaps. Tell us what you're thinking when we think about how we can expand our funding investments and what community partnerships should we be leveraging. And that it also includes our Healthy Start community as well, because we work together. We're working with the same families, and we have to be able to align what we're doing together to really build out what Alachua County needs or is asking for.
Right.
So one of the things Julie said that just made me kind of go, huh? And I would wonder why the woman who approached you when you were having your child said, this is a state program, you don't need it. Because that made, like, I don't know how many assumptions in one sentence. And so it's back to my, who's approaching you? How are they approaching you? Where are they approaching you? If the people who are doing the approaching have assumptions and biases about what it is they're offering, how are we going to engage people? And that then raises the question of, is that the best place to start that conversation, and where can we start it elsewhere? So that's one of my takeaways. Aside from the obvious, we have a huge issue with equity and poverty. We can't, to Lee's point, fund somebody, a mom, a woman's health before she's pregnant, because that's not what we are. But there are other people in this community that are doing that kind of work. And I think that, we've identified literacy issues, we've identified it seems to me that there's a women's health issue that we have a piece of. Can we convene? To ask these women, what is happening in your life, more specifically, because poverty is an easy word to use, right? It's kind of like the beauty pageant. I want world peace. It's easy to say, but what is it? What are the specifics in your life that kept you from going to, what's happened to you that has made it difficult for you to access? What would be helpful to you as opposed to what we think might be helpful to you? I just think we need to have our listening be more focused on what we have to learn in terms of both assets and barriers in the community to using these services. Is this a service that appeals to you? What is it that might appeal to you about it or not? What turns you off to it, other than it's a white lady who I've never seen before coming to my door and suddenly wanting to be, talking about stuff that I don't share, even sometimes within my own family. So those are my takeaways from what I've heard.
Thanks, Lee. Maggie, what you said, I wrote that down 3 times already and my hand is hurting. What we offer, where it's offered, and who's doing the offering, I think is really key. I think you summed it up nicer than what I could have, or more succinctly. And the themes on this little sheet here, I guess you want us to fill this out, but I think it's probably good. But just to ditto everything that Maggie said, I won't prolong the time with that. I think we have these inequities that continue to show up along racial lines, or be it zip codes or whatever. And what's really disappointing is we live in such a rich community, and with all the assets and resources that we have here in the university system and all, and still the Black folks in Alachua County, along all these medical lines, still continue to perform poorly than what the state does. And we see that in education data as well. So we got to figure out something. Our community is very, very generous in agreeing to tax itself more to try to address these issues. And I think we do, we got to do more listening and figure out a way of hearing from. I don't think we tried during the listening project that we did. I think we tried, but I don't think we got down to the people that we really need to hear from. And I don't know the solution to it, but I don't think I don't think we're reaching them. I don't think we're reaching them to figure out how we can help them best, or what help looks like to them.
I think that's the,
That's the linchpin, and I don't know how to do that.
So that's part of what the access listening sessions will be. The good part about partnering with the UF Maternal Health is that they've already started some of this work already. And so they're able to provide some of that information to us or share what they've seen so far. But now they're continuing that work and talking to, birthing families. And that'll be a part of what they're able to pull together and get information on. So in October, when I come back, that's the second time. When I come back, you will hear from, and I didn't say her name, Dr. Adetola, Louise Jocks and her team. You'll hear from them and the themes, what they heard while they were out there, listening to those. There'll be 7 listening sessions so far, all over the county. You'll hear that information. And then, of course, that will help inform our RFP as well.
But the key there is who attends the listening session.
Me too. I was thinking that too.
Dr. Hart.
Yeah, I'm always wondering, why is it that every other developed nation in the world, even Cuba, does so much better than we do on this? So I would really love it if Julie had an MPH student or an intern or somebody that could just go to the internet and find out what communities do in England or Scotland or Wales or Finland or Denmark or Norway. They do it so much better than we do. And I know our country spends a lot of money on defense and not a lot of money on social services, but let's get to the specifics of it. What do women in those countries get that women in Alachua County are not getting?
Thank you. Mia, as far as, you've heard a lot of good suggestions. When you come back, I would like to to hear, specifically, based on some of the data that we've seen, what we can actually address and what we can't, or really is beyond our control. Let's focus on the things that we can do, if it's some of the things I wrote down, the precursors, the smoking, the weight, the things like that, whatever we can do to start with that. And I think by starting these, if we can address it, they don't have to be pregnant. We can start this in school, don't smoke, watch your weight, because it leads to diabetes, high blood pressure, it's hell on your knees, all these things that we can't, hopefully we can influence. So, I want to applaud Julie. I want to applaud you, Mia, for the presentations that you've given. I think they're helpful. It does look like there's some positive things about Alachua County. I was concerned with some of the things like, as far as I'm concerned, Alachua County should be, better than everybody else, and that goes to some of the things that you heard from Maggie and Tina. When I ran for whatever 100 years ago, our poverty rate was 22%. It's probably about the same now. So poverty is an issue, and and I know that it's beyond the scope of the Children's Trust, but hopefully we can make a difference with what some of the programs that we do, that we can, because a lot of it is generational, that we can make a difference as far as at a generational basis. So, please bring us back, things that we can address or try to address in a comprehensive manner that gets the right people to talk to the right people, so that we can have the impact that we need. That's not much of a charge, I know y'all can whip it out by next week. But anyway, I applaud what y'all are doing, and, thank goodness that y'all are doing what you're doing, and we can't, you don't hear it enough, but we thank you very much for all that. So anything else? If not, we'll turn it over and get some public input. If the public would like to, can come forward. And if not, that's okay too. So, all right, thank you. Let's see where we are on the agenda.
A break. Wait, I think we have someone. Are you coming up to speak? Yeah, we have someone.
Yeah, I'm quick with the gavel, so.
So, got 30 seconds.
No, you got this, you talk.
Well, as I was listening and it brought back to my remembrance a quote by Dr. Bob Block. He's the former president of the American Academy for Pediatrics. Unfortunately, not every child will become an adult, but it is certainly true that every adult once was a child. And we have not paid attention to that simple phrase enough. And they are doing some great things around the world with the science, the new science that's not new. And I'm not sure we're really aware of it. Knowledge is power, and it's a powerful tool. So I'm Pamela Hawkins, and I run a nonprofit, Grace to Overcome Love Blooms here. We're just advocate well-being for improved youth wellness. And adverse childhood experience and toxic stress is real. Early childhood deficits from 0 to 3 is real. The first 1,000 days of birth are real. So I just wanted to say that when I was taking notes as I was listening, so I'm trying to, the gap that I think we're really missing is how toxic stress gets under our skin. And the developing child, the brain circuitry. It's not what's happening to us, it's what's happening inside us when things happen to us. And our African American women don't know what's happening to them. And they just need to, one, know that when they're at a level of heightened stress, when we're stressed, when we're stressed, I made notes so I wouldn't go rambling, but this is a subject that has me hot and bothered because I don't know if we're really aware of, and if we are looking at the latest scientific evidence for intervention and prevention, how are we disseminating? How are we actually saying we're developing programs and strategies? But if we're not looking through the lens of adverse childhood experience and not just the study, not that because we have other trauma that could happen that's not of the 10, but it's still the same effect when it's affecting how we even function. So we know when we are stressed, heart rate goes up, blood pressure goes up, stress hormone levels are activated, immune system's activated, all of blood sugar, all of that's happening. But if we are in fight or flight, yeah, great. But if we're not, if it's just because our environment, we're wondering how we're going to put food on the table, if we're worrying about how we're going to clothe, if we're worrying about, oh gosh, is the bear coming home? Is he drunk? What's going to happen to me? Then we don't know how to turn off that faucet. But there is hope. And through holistic hope, I need to talk to you because we have some solutions and we want to do our part to aid in. We have enrichment programs surrounding executive function, which is real. It's not something we're born with. We have to develop it. Core capacities for mostly with single women. Those statistics, I guarantee you, most of the women are single women. And actually adolescent, some of them, even I have a hypothesis myself with with the adverse childhood, that if we go back to adolescent pregnancy, we have children having children. We have undeveloped brains having children. But there is hope. If we can track this, we can track this. We can track the child with the asthma. If we know their history of adversity and missed deficits, we can follow that child and say, oh, you know what? We need to make sure they have these specific services for self-regulation.
Ms. Hawkins, I need you to wrap
All
it
of
up.
those. So that's.
Okay. No, that's fine. Hey, Ms. Hawkins, it's great to see somebody who's passionate. So,
Yeah.
yes, ma'am. Just had to break the seal. So now we can get some public input.
That's right. I think she gave me the nerve to get up here. Elizabeth Patton, mental health counselor, longtime resident of Alachua County. I've worked in many home visiting programs myself. So I know how hard that work is. And I think that, and I think it was Ms. Certain who said there's a mistrust of the system. And I think that starts very early. And I see it repeatedly in families, especially families involved with the Department of Children and Families. And I think that, that's kind of the first service that people are seeing in their home sometimes. And it can be just as traumatic as abuse. So I think rebuilding the trust and the systems that are out there, and I don't know how to do that, but I think we start early, and I think we can start with our kids. I think we can start in our schools. And I know that Florida Virtual offers a life management course. I don't know what's in the public system these days. But, we put so much pressure on our parents, our young parents, but we don't teach them anything. We tell them they can't, whip or get the belt out or, but we don't give them an alternative. And then they just throw their hands up and say whatever and just kind of, go on about the day and let the kids run. So I think we have a lot that we can do. I think there's a lot of hope. And I think we start early. I think we start in the schools because I think that's when they want to learn. I think that's when the young ladies want to learn how to take care of themselves because nobody talks to them about it. And that's a really great opportunity to bring in, our doctors, our nurses, our doulas to those schools so they can ask those questions and start thinking about those things. So I love this program and that's why I'm here.
Thank you, Ms. Patton. Okay, Tina, you got the challenge there. Anyone else? Well, thank y'all very much, and thank y'all very much for being here. And Mary, you can come sit up here. Right before we adjourn. So, thank y'all very much, and maybe y'all stay for the rest of the meeting, or the next meeting. This meeting is adjourned.
Okay, sugar time. I need a.
Yeah, you know, kidding.
Yeah, me too.
Chrissy,